Welcome to this mini lecture on edema. This particular lecture, there's two main outcomes, learning outcomes. Firstly, what is the definition of edema and what are the three main mechanisms that lead to edema? So firstly, let's look at what edema actually is. So edema is the accumulation of fluid within a tissue or even within a cell or cells. So it's where fluid accumulates in excess within a certain area or within certain cells that cause it to enlarge or increase in size. So there's two types of edema. There's intracellular edema or extracellular edema. Today we'll focus predominantly, or actually we'll focus completely on extracellular edema. But just really quickly, just so you know what intracellular edema is, it's where fluid starts to accumulate within the cells itself. So what would lead to fluid going into the cells? Well, basically they would have to, in comparison to the outside, become hypertonic. So if you were to have low levels of, say, sodium in your blood and in your tissue, which is hyponatremia, that would cause the cells to become hypertonic compared or relative to the tissue. Therefore, water would go into it. That would cause edema within the cells. Another cause of edema would be a problem with the sodium-potassium pump. So if that pump is not regulating, pushing sodium out, bringing potassium in, and the cells become accumulated with ions or constituents, then also the fluid would go into the cells and become swollen. And that's the other cause, or another common cause, of intracellular edema. Now, today we're focusing on extracellular edema. So this is fluid around the cells. So if you look at this diagram here, what we have is we have the arterial system coming into a capillary, and then the venous system leaving, going back to the heart. So up here we have the heart, okay, not drawn, but just in schematic. So we've got the left ventricle where blood leaves and goes aorta into the arterial body and goes into a capillary bed. Well, you've got thousands and millions of capillary beds, but in this case I'm just drawing one as a representative. So arteries, arterioles into capillaries. And this is what allows the fluid to distribute into the tissue and into cells. So the whole point of this is to bring fluid down or blood down into the capillary bed, and then hopefully what we will do is hopefully push the plasma out into the fluid. So the fluid between the cells is what we call the extracellular fluid, or sometimes referred to the interstitial fluid. And so the point of this is to take all the nutrients, take the oxygen, take the electrolytes, etc., to the cells, allow them to pick up everything they need, oxygen, nutrients, vitamins, electrolytes, etc., drop off their waste, and then hopefully the fluid or the plasma gets sucked back into the capillary at this end, and then gets taken back into the venous side, back up into the heart, to go to the lungs, and then do another cycle through. So that is essentially the point of why we have this cardiovascular system, and to put fluid out to bathe the cells and to drop it back so we can survive. Now the way it does this is through two main mechanisms. It's what we call a hydrostatic force and an oncotic force. So the force that's pushing the fluid or the plasma out of the capillary bed into the interstitial space or the extracellular space is what we call the hydrostatic force. Okay, so we'll put this as the hydrostatic force or the hydrostatic pressure. Okay, so that's the force that's generated to force the fluid out into the tissue. Now remember, this is coming from the arterial end, so you're kind of going through the capillary network. It doesn't look like this is very simplified, but essentially you have the arterial side of the capillary and then the venous side of the capillary. So the force that's pushing the blood plasma or the plasma out into the tissue, that would be on both sides, is the hydrostatic force. Now the hydrostatic force comes from the blood pressure, so it's coming from the pumping of the heart, and we know that that is approximately 120/80. But as you get down smaller and smaller and smaller, and you come into the arterial end, and now you come into the capillaries, okay, the pressure has dropped quite a lot, and so now it's reduced to the force being 35 millimeters of mercury. So that's the hydrostatic force in the capillary side. Now, the other thing that's working is all the kind of plasma proteins, so all the big things that are left in the capillaries. So you've got these big plasma proteins like albumin, like fibrinogen, like globulins, etc. And that is causing an oncotic pull, okay, or an osmotic pull to pull the fluid back in. Okay, so that's like an osmotic gradient to try and suck fluid back into the vessel. Now this is what we call the oncotic force, okay, or the osmotic force. And so I'll do this in another colour, and this is approximately 25 millimeters of mercury. So this is the force that's trying to bring the fluid back in. So you've got a 35 hydrostatic pushing out, you've got a 25 oncotic or osmotic pull back in. So what you can see there is we've got actually a net pressure, outward pressure. So this is the pressure forcing the fluid out of 35 minus 25, which is 10. So the pressure is 10 millimeters of mercury. Okay, that's the net filtration pressure. That's what's pushing the fluid out into the tissue. 10 millimeters of mercury of a pushing. Now there are other forces, but I'm going to leave this out today. The other forces are either an oncotic pressure within here, so that's pressure sucking fluid through osmosis into the actual cells, but also a hydrostatic force pushing the fluid back out. But I'm just going to stick with these two forces today, which is the hydrostatic force in the capillary bed and the oncotic force pulling the fluid back in. So as we move through the capillary bed, not only are we losing fluid out, okay, but because we're getting to a bigger diameter, the hydrostatic force, okay, will start to drop. So that's the fluid pushing out. So the hydrostatic force at this end, at the venous end, drops to 15 millimeters of mercury. So that's the hydrostatic force, the forces that are pushing out. So that is now 15 compared to 35. So it's dropped quite a lot because we've got a bigger vessel diameter, but also we've lost some fluid. Whereas when we come to the venous end, okay, we've still got all the plasma proteins in it. We don't lose much plasma proteins in that plasma, so that force or that number stays about the same. So we'll call that again 25 millimeters of mercury. It will actually go up a little bit, might go up to 28 because the blood plasma is actually a bit thicker now, but essentially we'll keep it the same. So what we have now is 15 millimeters of mercury forcing the fluid out and 25 millimeters of pressure sucking the fluid back in. So the pressure difference is now gone the other way. So now we have a net filtration pressure of 10 coming back in. So that's going to bring the fluid back into the end of the capillary and then bring it back to go back into the circulation. And that's essentially how the fluid will go out at one end and be brought back in at the other. However, There is one more level of complexity, and that is what's happening in the tissue. Now I'll draw it with blue. Now with the fluid coming out, as I said, most of it is just plasma with water, with electrolytes, but there's also going to be some plasma proteins that will escape out. So some plasma proteins will escape into this space like so. These plasma proteins could be albumin, fibrinogen, and the gamma globulins, okay, or the globulins. So these are the big proteins within the blood, okay? So some of it will escape out, so that some of that will remain in the tissue. Now with that increased amount of plasma proteins, fluid can get sucked into that as well. So if this wasn't taken out of the tissue, fluid would retain and stay in there, which would cause all this to swell up. So we've got another system that helps to drain it, and that's the lymphatic system. So off the side here we actually have a lymphatic drainage system which comes off and goes up, and then it will drop up into the thoracic duct, up towards the heart. So this will actually help to drain the tissue and the plasma proteins. So any excessive fluid would come this way and drain this way, and you would get rid of it that way. So with this in mind, you've got a hydrostatic force, you've got an oncotic force, which is bringing it back in, and you've got a lymphatic drainage. So these are the three areas that we have the fluid dynamics. And this is kind of the three mechanisms of how, if it doesn't work, how you will get edema. So therefore, there are three main mechanisms of how you will develop edema. Now remember, edema is excessive fluid in this interstitial space, or excessive fluid within a body cavity, such as within your peritoneum, or such as around your heart, pericardium, or around your lungs, pleural cavity. So that's excessive fluid in those cavities or within the tissue. Could be in your arms, in your legs, etc. So the three mechanisms that you will get edema is either too much fluid is leaving, so increase plasma leaving capillary. Okay, so that's excessive capillary plasma leaving the capillary. Okay, or not enough fluid coming back in, decrease plasma returning. Okay, and then finally a decrease in the drainage. Decrease fluid drainage. So they're really the three main mechanisms of what causes edema to occur. Okay, so it's either too much fluid is forced out, so this is generally a hydrostatic force problem. Not enough plasma is coming back in, that's usually an oncotic problem, or not enough fluid is drained out. Okay, so decrease in fluid drainage, and this is usually a lymphatic or within the tissue, there's a problem there. So, finally, before we finish off, I'm just going to give you, firstly, expand upon how these three can actually have subcategories, okay, which are more important from a clinical standpoint. And then I'll give you some examples in a clinical perspective of what causes each one of them. So firstly, with number one, this is an increase in hydrostatic forces. So let's start. The main way that you can do this, or the main way that you can get plasma leaving the capillary, is with usually the artery or venous end. So, as we spoke about, you've got blood pressure that's coming down and forcing a hydrostatic pressure within the capillary bed. Now you can see it's 120 here, and here it becomes 35, so it's dropped off in its pressure quite significantly. But what would happen if you had a person that had hypertension? So if you had a person, let's say, that had 160 over 100, you would think, well, that should bump that up to, say, 55. But there are certain mechanisms that protect the capillary from getting too much pressure, particularly around here. So there's what we call a pre-capillary sphincter. So there's a sphincter around here with smooth muscles that would contract and narrow or vasoconstrict, okay, to keep that number at 35. So if your blood pressure is high systemically, your pre-capillary sphincters would start to contract and to keep that number in that case. So with a person with hypertension, you don't get an edema from it. Okay? So that's at the arterial end. Now, if you were to have a problem with the permeability here, so we know that if you have inflammation, two things happen with inflammation. You either have vasodilation or you have an increased permeability. And so this can actually cause edema from the arterial end. So if you were to have an injury, let's say you rolled your ankle, we know if you were to roll your ankle, you do get edema, so your ankle swells up. So what causes that? Well, at this end, we get all those cellular responses, so the inflammatory mediators release, like histamines and prostaglandins. That would cause the pre-capillary sphincter to dilate. So that would get bigger, okay, bigger, and that would increase the hydrostatic force, as well as the endothelial cells here, they would constrict and move further away from each other. Therefore, fluid can exit through here much easier. So the first one here would be through inflammation. So inflammation. Now the way the inflammation causes edema is both vasodilation, increase in the size of that entry point, therefore this number would go up. And then also the endothelial cells will contract and more fluid would leave out. So that's one cause, or one example within the first one. So that's more fluid leaving the capillary. Now at the other end, the venous end, what would happen if you increase the pressure within the venous end? A good example would be, well, if you've got a thrombus. So if you were to have, say, a thrombus build up in your venous system, that would cause the pressure into here to get through much harder, so therefore extra fluid would go back into the capillary. So an example of that is a deep vein thrombosis, like in your leg, or maybe if you had an incompetent venous system like varicose veins or incompetent valves, this drainage would be decreased, therefore fluid would go back in, therefore this hydrostatic forces here would increase. So instead of 15, let's say it goes up to plus 10, so it goes at 25. So if that's 25 and that's 25, therefore fluid can't be brought back in because we don't have that net filtration pressure now. It becomes 0, so that no fluid is sucked back in. Therefore, fluid will remain out in the cells, or the tissue, should I say. Therefore, you get edema. So that could be through a venous blockage. Or if you just had, let's say, if you put a rubber band or a tourniquet around someone's arm, okay, and that would cause blood flow can still come down to your arm through the arterial side of things, but blood, because you've constricted it with the tourniquet or the rubber band, blood can't leave, so it would be constricted. Okay, so there would be a blockage there. Same thing would happen. Fluid would go back, build up in here, increase hydrostatic forces, fluid doesn't come back in, therefore we get edema. Or it could go all the way back to the heart. What would happen if the right ventricle, which is down here, right ventricle, which needs to pump blood to the lungs, what happens if that fails? So if that fails, right-sided heart failure, it would go back into the right atrium, then come back down into here, and then go back, and the same problem arises. You get an increase in venous end hydrostatic pressure, therefore this all becomes pressurized, then therefore fluid can't come back in, therefore you get edema. So right-sided heart failure can also do this into peripheral edema. So another cause of how plasma leaves the capillary is an increase in hydrostatic forces. So within that category of excessive amounts of plasma leaving the capillary, it could either be through an inflammatory cause or just excessive heat. If you were to put a heat pack on someone, that would cause vasodilation, and that would cause that as well. So they can get edema from that. Or increased hydrostatic forces, which is generally from the venous end. Now the reason why that occurs at the venous end, unlike at this end, it doesn't have a capillary around this. It doesn't have a sphincter around this. So it can't constrict like at the arterial end when you have a high blood pressure. When you have a high venous pressure, it doesn't have that luxury. So whether it is a thrombus, whether it is an occlusion or a constriction, or whether it's a heart failure, it will keep going back and cause that force to increase. Okay, so that's two examples or two subcategories within the first one. The next one, what would decrease the plasma returning into the fluid? Well, this is all working at this level. Okay, so we know that we have a sucking force, okay, or a drawing force, or an osmotic force of 25 millimeters of mercury. Okay, that pulls the fluid back in. What would cause that to decrease? Okay, well, basically anything that would decrease the amount of plasma proteins within the capillary. So if you have normally these plasma proteins such as albumin, such as fibrinogen, such as globulins, if they decrease, so you start to kill them off or they're not produced, okay, that would cause this number to decrease. Okay, so that number would go down. What are some examples that could cause that? Well, if you have problems with your kidney, so your glomerulus, which only lets out generally plasma and all the things that is dissolved in it, doesn't let through red blood cells, doesn't let through white blood cells, doesn't let through plasma proteins. But if you have a glomerulus issue where your glomerulus becomes leaky, all this plasma proteins gets passed through your urine and you pee it out. Therefore, your levels of plasma protein drops. Therefore, this 25 number becomes, let's say, 15. And therefore, we don't have that drawing back force back into the capillary. Therefore, we get edema. So the best example of the plasma not returning is a decrease in plasma protein levels. So a good example of how you have a decrease in plasma protein levels is either A, your kidneys are excreting too much of it, such as having nephrotic syndrome or a glomerular issue, or number two, you don't make as many as you should, such as if you have liver failure, your liver might stop making the albumin and so forth. Therefore, you don't have as many plasma proteins. Therefore, you don't have that drawing force. Okay, so that's another one within that. So far we've got three. 1, 2, 3. Finally, we move to the fluid drainage. What causes a decrease in fluid draining out of the tissue? Well, a good example is if you have some problem with your lymphatics. So if you have certain nodes, So let's say this is a lymphatic node, okay? If this becomes blocked up with an infection or it becomes blocked up with a cancer, that's going to cause this to decrease in drainage, therefore fluid would stay off in the tissue. And this is a type of lymphedema, okay? So that could be either infection within the lymph node, or cancer within the lymph node, or the lymph has been radiated for cancer treatment, or maybe it's been removed. So they've pulled it out to help with, say, cancer, like breast cancer, take out the axillary nodes, therefore this can't drain, becomes scar tissue, and then fluid stays behind. That's going to cause a problem. So if we have a decrease in lymph drainage, okay, or another one would be that kind of works at the same level. If you, because remember we spoke, plasma proteins will go into the tissue at a small amount all the time, and they usually get taken back into the venous circulation through the lymphatic. But if you have too much plasma proteins or certain things within the tissue, that's going to cause fluid to go into it. And a good example of that is an increase in plasma proteins, or let's say sodium, in the tissue. So if you have excessive amounts of sodium ions or plasma proteins that will retain in that, fluid will go to that as well, or water will go to that as well, which will cause that to swell. Okay, so an example of this one, which is a good example, if you have either a high salt diet or you have a problem with excessive amounts of aldosterone being secreted in your blood, so that could be either a problem with your adrenal glands, or an increase in the RAS system, or an increase in salt in your diet. As we know, salt or sodium can go through the capillaries quite easily, but if we have lots of sodium in here, lots of sodium in your tissue, lots of sodium in your tissue, not in your cells, but just in your tissue, what will happen is water will follow it, so more water will come out, but also the fluid in the cells will drain a bit because sodium can't go into the cells, so it becomes much more hypertonic out here to the cells, therefore excessive fluid remains in that tissue, which causes it to become increased, or that causes the edema. So just to recap on that, there are, in total, we said there's 3 main mechanisms, but in total there are 5 things that could cause edema. There is, the first category is increased plasma leaving the capillary. This could be caused by 1, inflammation, which is a combination of vasodilation and permeability changes. Vasodilation would increase that number. Permeability would just allow more fluid to go out. An increase in hydrostatic forces. Okay, this could be generally coming from the venous end, can be from a blockage, compression, or right-sided heart failure. Will increase the central venous pressure, which will go back into the venous end of the capillary, which will force the hydrostatic pressure to go up. So instead of down this end being 15, now it goes up to 25. That causes edema. Or number 2, a good example would be a decrease in plasma protein levels. That would be like in kidney problems or potential liver problems. And then finally, number 3 is fluid or the constituents aren't being drained out. This can be caused by a lymphatic drainage problem, whether it's obstruction, whether it's been damaged, or whether it's been removed. It can't get back into the blood. Or there's an increase in constituents within the tissue itself, and that causes excessive fluid to stay around the cells, and that causes the person to become swollen and edemic. Okay, so that's the main examples of how we get edema. Finally, I just want to point out how the edema would appear. So sometimes you would have heard of the term pitting edema or non-pitting edema. So what that basically is, if you were to press on someone, so you put your finger into the tissue, up like this, okay, let's say it's in their leg, you pushed into the tissue, if that, where you pushed it in, stayed pitted, that is what we call pitting edema. And why that occurs is, as you push your finger in, all that fluid would disperse, okay, and it would cause it to stay plugged in, okay. Now the two main causes of pitting edema are going to be the increase in hydrostatic forces or the decrease in oncotic, which is this one, decrease in oncotic pressure. So this is either you've got an increase in hydrostatic forces pushing the fluid into there, like we saw in heart failure, okay, or like we saw with the compression, or a decrease in the oncotic pressure. So you have the plasma protein problem. Fluid goes out in the tissue, you push your finger in, fluid would disperse, it becomes pitted, okay? An example of a non-pitting edema is when fluid stays in the tissue but it's under high pressure. So you've got lots of plasma proteins in it, so when you push your finger in, the fluid doesn't disperse out because it's held in there by all these things in the tissue, and therefore the fluid can't disperse out and then come back in, it just stays there. And that would also happen in inflammation, because as you know with inflammation, not only does fluid come out, but proteins comes out. And so that would cause the area to be swollen, and you could push it in, it wouldn't cause it to pit. So example with the swollen ankle, when you roll it and it's swollen, you push your finger in inflammation, it doesn't pit, okay? That's because there's a lot of stuff in there that holds the water. So you would get non-pitting edema in, say, that case, and also these cases. And so why I'm telling you that, because as you hopefully know, a treatment for edema, or at least one type of edema, is diuretics. And diuretics will only work to the pitting edemas, okay? So for these ones, because we've got all this extra fluid there, and so when you take a diuretic, you pull the fluid out of the blood because you're urinating a lot more. That means more fluid will go back into the system, and then you can get rid of that extra fluid much easier. But in the non-pitting edema, where the problem is more, say, in the tissue that's sucking the water into it, okay, or not being drained out, so it's pressurized, changing through a diuretic is not going to pull the water out because the water's staying behind to get stuck with all those extra things like extra sodium or extra plasma proteins, or the lymph is blocked, okay? So that's basically telling you, from a clinical point of view, the use of a diuretic is very useful, say, in heart failure, okay, when there's a backage like this, or when then there's problems with the plasma proteins, but it wouldn't be so good for things like when there's a lymph or a problem in the tissue itself. So that has hopefully helped you with firstly, what edema is, what the definition of edema is, but also some of the common mechanisms of how it leads to. So we know that there's three main mechanisms, but there are subcategories within that which make a total of 5. And these 5 could be an inflammatory case where there's vasodilation and increased permeability, where an increase in hydrostatic forces, which is generally coming from the venous end, such as heart failure or thrombosis or constriction. And number 2, decreased plasma getting pulled back into the capillary. This is usually caused by a decrease in oncotic forces, which is caused by a decrease in plasma proteins. And then finally, number 3, a decrease in fluid drainage, which could be either through a decrease in the lymph drainage, or there's too much constituents in the tissue, such as salt or plasma proteins, that hold the fluid in there between the cells. So I hope that's helped, and that's the mini lecture on edema.